Morbidity Clinic. In fact, we are having the morbidity and the mortality clinic once a month since 2014, and morbidity clinics were added in 2017, and regular activities was being done. Today, I have a special purpose of presenting this morbidity clinic because in the hospitals we are managing the patients, and we have a arena of gadgets, high-class sophisticated facilities, 230 faculty members mind behind the working of the patients, but it is not so when we go to the community. So that's why this morbidity clinics provide enormous opportunity and also like windows to see the world through the lens of the morbidity clinic. And that is what the topic is today. It is a morbidity clinics window to the clinical precision and public health. Learning from the morbidity clinics. It is a group of presentations which I have compiled from the different faculty members' presentations, and I will be discussing some of the aspect of how the clinical precision is another area where we can enhance our capabilities. As we all know that mortality is very much visible, it is obvious, it is easy to identify also, and also it is available in the records. Mortality statistics are considered to be one of the most reliable and used all across the world. It has been seen that the higher mortality in children especially is considered an indicator of the poor health of the society. Not so for the elderly people because there is a age-related cause of the death in these patients. Various indicators are used to measure the mortality which are available in the populations are crude death rate, child mortality rate, life expectancy at birth, etc. And most widely used is the infant mortality rate, which indicates the health services to the community. On the other hand, morbidity is a departure from health. It results or has a potential to result in at least some restrictions in the performance of our normal activities of the life. Some are visible, some are obvious, and it depends on the how observant the physicians or the family members are, but sometimes they may be invisible, like mental health problems. And they can cause a lot of disability in the society, loss of productivity, loss of economic growth of the country. Also, morbidity is not so easy to quantify as compared to the mortality, and there are many ways to quantify it. The public health experts, the community medicine, family medicine people use different indicators. The epidemiologists use different indicators. And what we come to know is that there is a morbidity bathtub. Now, any new case which is occurring in the community is known as the incidence, whereas the conditions which are prevalent or they are existing in the society are the prevalence rate. That depends on the death in the society and also the recovery. So if the recovery is fast and if it is it is equal for everyone, the prevalence will decrease. Also, when there is a death rate is very high, then also the prevalence will decrease. Any conditions which result into lower death rate and decreased recovery will lead to the increased prevalence of the conditions, and that is what we are going to see in the coming generation next 20-30 years because of the aging population, when they have more of the problems of the continuing problems because of the increased life expectancy and the better care in the society. So morbidity and mortality clinics are a very important source for assessing our health services because they provide the safe space for the learning. They are multidisciplinary. There is a systematic agenda with the support of the clinical analytics which is available, and there is a comprehensive discussions on these. That also leads to the documentation of the lessons learned and also the support reporting pathways to support learning and recommendations. At AIMS Jodhpur, we are committed to having the excellence in the educations, and that's why we are having all the recordings of these CGR, CPCs, and the institutional activity in our record. Mortality reviews are very important, but the people are afraid to present in front of the audience, and the reason is that there may be many reasons, but there is the most important impact of the mortality reviews is that we understand the circumstances of the cases. So every case can be like context can be different, and it is not the sole responsibility of the treating physician or the surgeon to cause the death. It also provided us an opportunity to determine if the case could have been prevented. So that is also very important. Improve the quality of the care and delivery of the services. That is also as an outcome of the mortality reviews. Identify and address the systemic issues and design the best practices to reduce the preventable deaths which occurs in the hospital. So one of the case which was presented by the pediatrics department, in which a patient came with a pneumonia, gradually deteriorated and went on the ventilator, and later on he has a lot of issues because of the ventilator associated infections and because of the leaks in the airways which lead to pneumothorax and superadded infections. So our team did the primary assessment. They found out the various area in which we can work on, and they designed this algorithm and the pathway of the management of this child. They have beautifully found out what are the steps which has been taken right from the day one. They also did a fishbone analysis. What is the cause of this prolonged morbidity in this child? And they come out with various solutions. And ultimately, there was a bundle which is known as ICU Liberation Bundle. Now, these bundles of care are very important in the quality care because bundles reduce the cost, they increase the effectiveness and the efficiency and also the outcome of the patients. So there are various bundles, they are being handled in various ICUs, whether it is in an ICU, PICU or adult ICU. And this ICU Liberation Bundle is based on the ABCDF, in which the assessment, from the assessment to the pain relief, to the degree of sedations, to the patient's breathing status, and how we can wean off the ventilator, they are all discussed during this presentation. So this come out with a very good message, that is, if we could have prevented this much pressure at that time, we could have reduced the morbidity in this patient. The child survived and he is now well. Similarly, this was a case which was first referred from the periphery, and a MRI was done immediately, and it was found to have the space occupying lesion. So it was referred to the neurosurgery. Despite having the management, the patient was not improving and there was continuing encephalitis. It was later on termed as a neuroencephalitis with a abscess. To our surprise, there was a referral from the different departments, and this case designate that how the multidisciplinary team with a fast acting efforts can reach to the diagnosis. And ultimately they were able to find the solution that the skin involvement was the reason, and this was from the field, from the community. When the patient was working as a farmer, he got the infection in the feet and the hands. And this leads to dissemination and reaching to the brain also. This condition is known as Balamuthia. So Balamuthia is one of the condition which is now being recognized. Many cases have been now identified by the Department of Medicine and Infectious Disease. So this Balamuthia mandrillaris has been presented in our morbidity clinic by Dr. Deepak Kumar, and he says that the most important features are the fever, headache, vomiting, letharginess, mental health changes, weakness, confusion, and partial paralysis can also occur because of the brain involvement. This again gives us a concept that is the environment, our human body, and the animal dealing can result into many disease. And this is a concept of the One Health, which is now being occupying most important thing. The community medicines are creating advocacy for that. Department of Biotechnology is producing the scientific literature which can corroborate that, okay, the disease are occurring in the community because of these reasons. IIT Jodhpur has also taken an initiative. They have designed a good concept that is known as THAR design. So One Health is from the ecological conservationist to the life science to the animal husbandry. It goes from the human to animals and the environment. And the strategy which has been identified to help in this situation is observe, identify the patterns, and develop the predictive models using technology, and also manage these patients. So another situation which can be which we come across very commonly is that the patient being diagnosed with a very unusual condition. So this 4-year-old, 10-month-old female was referred to the one of the hospitals in the Jodhpur city with a breast enlargement for last 2 months, and she also had the bleeding for a vaginal 2 episodes 1 month apart, and there was a abdominal distension was also noticed in her. There was increased body hair noted since the last 2 months, but there were no pubic or axillary hair. The parent also noticed that the child was excessively lethargic and intolerant to both heat and the cold. So this case was worked up, and the ultrasound examination, it was found to have the ovarian cyst. And it was because of the ovarian cyst, large ovarian cyst, the child was referred to AIMS Jodhpur for management. And he was evaluated by the pediatric endocrinologist. And the clinical impression was it is a result of the precocious puberty. It is a isosexual in nature, and it is whether it is a central or peripheral. So most likely to be peripherally found out by the team, and there was symptoms of the hypothyroidism. So the workup was done, and to the surprise, it was found that the TSH was very, very high. So a simple investigations had picked up this condition, which is known as Van Wyck-Grumbach syndrome. It is a rare manifestation of a severe hypothyroidism. We commonly come across hypothyroidism. Some of our residents are also having hypothyroidism, and this is widely prevalent in the community and can have this different manifestation, varied manifestation from subtle changes in the behavior to the severe depression. So that's why this is very important that we have to identify these long-standing hypothyroidism, and we have to get back with the help of a simple biochemical investigations and manage this patient. So this child was identified. Luckily, there was no surgical intervention, and the treatment was started in the form of thyroxine in a small dose. Later on, it was increased to 75 microgram per day, and the patient has all features disappeared, and she is now developing normally. She is having no ovarian cyst on the ultrasound. Similarly, a snake bite is a very common in Rajasthan, and this snake bite has been taken as a challenge by Dr. Maya Gopalakrishnan. She has taken this lead along with the pediatric Dr. Bharat Chaudhary, and they have worked out many of the cases with the snake bite. And they found that a snake bite is a passive population problem throughout the world, but more in the India, and Rajasthan rank 6th. Within the India, Chhattisgarh, Uttar Pradesh, Rajasthan have the greatest age standardized death rate because of the snake bites. And the problems is, or the challenges is the regional venom variations are there. And one of the snake, which is known as Achis socoraki, produce the serine proteases, which lead to the ineffectiveness of our usual anti-snake venom. And it was proposed that the camel anti-snake venom can be the most important global method of generating the anti-snake venom, which can be used in many of the species. Otherwise, these are prepared in some of the laboratories in Chennai. So they also did the detailed analysis of this morbidity case of the snake venom, and they found that many of the things which were done were avoidable. For example, the plasma exchange was avoidable. There was a multiple transfusion of the blood was avoidable. The X-rays which were done 17 times were avoidable, and also the antibiotics probably was not required in this case, but it was given for 20 days. So these are the benefits of the morbidity audit. They also did the fishbone analysis, and they found multiple parameters from the place, because there is a regional variation, to the provider, lack of awareness, and the different expertise, different availability of the procedures. Then the policy of the institute or the country or the state. The patient's role is also very important. Not every patient is same, and they may respond differently. And there may be others, like there can be screening in the blood, screen for the blood in the abdominal cavity, which can prevent the death of this patient and also ultimately to prevent the snake bite morbidity. So these audit also provide a wonderful opportunities and the window of opportunities for taking care of this solution. While we talk about all these conditions, they are all, that they are coming to the hospitals in a tertiary care centers. But what about the common disease which are there in the existing in the society? We never thought about this. And India, what we see in the hospital is just the tip of the iceberg. So that means there's a many cases also roaming about in the community, which we don't handle them, which we even not able to diagnose because of multiple reasons. And about half of these cases, especially diabetes and hypertension, are not aware that they are suffering from these disorders unless we do some detective methods. So this 20% of the adult population which is visiting the OPDs, they are not aware that they have diabetes. And our country is the third biggest in the world to have the diabetes. If the primary care physicians can be trained how to tackle the diabetic epidemic, we have a much more better society. And there is a natural history of the diabetes. Initially, patient is totally normal. There is a pre-diabetic stage in which some of the biomarkers will be helpful for diagnosing the pre-diabetic condition, and ultimately the patient develop clinical diabetic. And the diabetic complications are also enormous, ranging from the heart to the vessels to the eyes, brain, and the kidney and the skin. Any organ can be affected. And sometimes this is the first time they are being diagnosed as the diabetic condition. So early diabetes detection is very important, and there are certain potential warning signs. And sometimes who are very intelligent people, community people or the public, they have become aware of why I am passing more urine than normal, why I am having infections in the skin, which is a fungal infections, why I am feeling so exhausted, why I am having a weight loss, I am eating more and still weight loss, and why I am hungry, I have taken the meals. So these are some of the indicators, but again, this depends on the expertise of the primary care physicians, that how detailed the history he take, and also on the intelligence of the person who is having this disease. So screening for diabetes is one of the method, but again, the screening program is very costly, and it requires a lot of efforts. It also requires a lot of arrangements. So that's why these screening programs are failing in our country. To add to this, some of the screening programs are too invasive, like taking the blood samples, proper precautions before the blood samples, getting the report. Again, they all present the enormous challenges for the community to find out the diagnosis. So one of the innovation which has been carried out by the Department of Endocrinology at AIIMS Jodhpur, with the help of India-Sweden Innovations, that they proposed that whenever there is a diabetes, there is ischemia, and also there is a dysfunctions, autonomic dysfunctions. There is a temperature regulatory dysfunctions. So why not we use the infrared thermography as a method of a non-invasive detection of the diabetes? So this method was devised by the endocrine team, and they presented in the Hamburg, Germany, in one of the endocrine conference, and it was appreciated by all that this is one of the area where the less resource country like LMIC can work on this area, and we can have the better detection. Although the caution is there because they may give a false alert also. So that's why we have to be very cautious, and we have to validate this screening program before implementing in the community. Again, one of the common conditions which we often come across is the patient with a weakness. Just day before yesterday, we had a call from the emergency that one 30-year-old girl has come with the numbness and weakness in the lower limbs. We became very much aware because nowadays we are seeing a lot of patients with the GB syndrome and immunological type of encephalitis and polyneuritis. So the resident was about to ask for the MRI, but the doctor, Dr. Bharat Chaudhary, did a detailed workup with Dr. Lokesh Saini, and they found that there are some indicators which are not suggesting it is a weakness or there is something else, and they just observe the patient. So a costly MRI was avoided, and the patient was found to have the functional disorder. Similarly, Bell's palsy, which is so common, and because of the lack of time, we increase our investigations. Because in a busy OPD, you have a cap of 50 patients, and you have to see the patient in detail at least half an hour, 45 minutes. And sometimes there is other patients who are waiting and they are aggressive also. So you compromise on the clinical examination and go for an investigation just to buy the time for the patient. And if they are referred for unnecessary investigation like CT scan or the EMG of the facial nerve and also MRI to rule out some pontine lesion. And it has been found that the economic impact of the diagnostic imaging in the workup of uncomplicated Bell's palsy is totally avoidable. No need for any investigations. If you are seeing an uncomplicated Bell's palsy with a full thorough clinical examination, you can save at least 25 to 30,000, and also the time he spent in investigations getting the report done. So this is an economic impact of how we can increase our clinical acumen, clinical expertise, and we devote more time with the patients to work up thoroughly. So this is what has been found here also. So whenever we talk about this precision medicine, though it comes to our mind, it is only related to the genomics or very hi-fi investigations which are required for the personalized medicine. It is not so. Indeed, the personal approach that is an inherent part of the doctor-patient relationship is a central aspect of the precision medicine, and it is not a new invention. However, new biomedical information might add substantial information beyond the signs and symptoms that were previously observable. For example, in case of that polycystic, the ultrasound picked up the polycystic villous abdominal distension, but again, some of the signs may not be able to pick up with the help of clinical judgment, and they required some investigation. But the term precision medicine implies the novelty of this concept, which is the incorporation of the wide array of the individual data, including the clinical, lifestyle, genetic, further biomarker information. So that is very important. So we have to understand that we have to use judiciously all these different markers. And among them, for the medical doctors, the clinical examination is a must, and it is a very important part of the evaluation. When you do the clinical evaluation of the patient in detail, it not only gives you a more insight in the patient's conditions and learning about the disease, it also builds the trust. It also builds the rapport with the patient. And they become aware that, okay, you are interested in us. So that's why this becomes a precision clinical medicine. So rather than going for the genomic markers or other markers, if we just devote time in our clinical precision medicine, much can be improved. And there are now facilities available to do the investigation of this patient. And expert is just call away. We have a 230 faculty members, 700 junior residents and senior residents, full of knowledge and expertise. They can be contacted anytime. Why not we use all these resources in the hospital and also in the community? So All India Institute of Medical Sciences has taken this initiative of a unique medical education model, which we started in 2012, and gradually build up with the quality improvement in the services. We started with the integrated teaching from 2013, ambulatory clinical postings, the orientation programs in different stages, and also unique program of collaboration. So all this led to multiple research, and we have been considered to be one of the top among the new aims to have the research. So apart from this research, we have a unique opportunities for the clinical precision medicine. And one is the School of Public Health. The School of Public Health the concept was born in 2013 when there was a visit from the Harvard faculty members, and they thought of a collaboration, but ultimately it was presented in Bhubaneswar also, but it did not materialize. We got it approved from our academic committee and GB, and it was started in 2017. Few hiccups during that 17-18 years, but this public health has now grown into a overarching umbrella in which there is a research, there is academics, and the practice. Research is attracting a lot of grants and the projects from different parts of the country and abroad. Academics, we have a very good now academics in the form of masters in public health, and an executive program of 6 months with a blended learning model. And also, we have just embarked from this July session on a very unique program that is known as MD-MPH program. This MD-MPH program is a unique in the sense because all the INI set selected students have an option to get it selected through these. 10 seats are there, and within 3 years of MD and 1 year of post MD senior residency, they get 2 degrees. And this is globally recognized. That is, once you are MPH, you have a more wide knowledge about how to apply your expertise in a particular area. So these are some of the things which are happening under the School of Public Health, and also School of Public Health along with the other clinical departments like medicine, microbiology, pediatrics, obs and gynae, cardiology, endocrinology, neurosurgery, neurology. They are reaching to the outreach program, and Professor M.K. Garg is having the outreach cell chairman, and he's going out to the community, school health educations. The Ayushman Bhav program is also being taken care of through this, and we are also conducting many trainings and advocacy for the healthcare. I think when we are working in the hospital, tertiary care hospital, we are learning more to be applied in the community. And apart from this, we also have the MD, PhD dual degree program, and also shortly going to start from January 2024, the MD Family Medicine. This is a unique program which has been developed by 11 AIMS, along with the PGI Chandigarh and JIPMER. And this is mainly targeted about what is known as the clinical precision medicine. And it is the multiple long-term conditions. So if we talk about the patient with the diabetes, he is not only having diabetes, he is also having cardiac problem. He is also having retinal problems, skin problems. And apart from that, invisible problem, mental health, psychological stress. Similarly, all the disease, when we talk, we see in a telescopic manner of a particular disease only. But the patient is having multiple other problems. That is known as the multiple long-term conditions which result from a single disease. And Center of Facts, this is a concept which was born by simple interaction with the Ministry of Tribal Affairs, and they just started with a tribal healers. What is the tribal healers approach? And what are the indigenous practices? Inquiry into that led to the development of a satellite center at Abu Road. Now this not only led to this tribal center, it also enhanced our communication skill with the tribal center through telemedicine. So all the major clinical departments are connected with the patients in the tribal area. And also recently we did the DREAM project, that is a drone assisted medical care at Abu Road. This was highly successful. It was unique in the sense that it is out of the hilly areas in a tribal area. So this was also appreciated. And recently also we have launched another program which is known as resident doctors in the tribal community. And these are the resident doctors who are going for 6 days, and they are learning so a lot. The feedback is so encouraging that they are interacting not only with their colleagues from the different departments, they are also interacting with the medical officers posted there. They are interacting with the Ashas, Anganwadi workers, and the school children. And here they have a lot of time to take a detailed history of the patient. So they are thoroughly examining a person in detail, including the family history, their social history, their the type of living they are living, and that is all covered in that this tribal health residency program. And this is a unique opportunity. I think whatever they are learning and the feedback is given, we can customize our syllabus, our curriculum in that direction. So this is in fact, it is a umbilical cord model. Umbilical cord model is that the bad blood comes to the tertiary care center, then the fresh blood goes to the periphery, and then they learn something new or something which needs to be corrected, and they come back with the ideas, and we find out the solutions, and ultimately it will lead to the policy development with the state government also. So after all these things, considering our institute as one of the important in the national ranking framework also, the NIHR, National Institute of Healthcare and Research, they gave the grant in which the two main lead applicants were the Public Health Foundation and the University of Leicester. And AIMS Jodhpur, Hriday Foundation and Kathmandu Medical College were the co-applicant. And this was the aim. That is it is a large ecosystem to improve the care of the people living with conditions which require a long-term care, especially in the country like India and Nepal. And there are four important pillars. One is the research capacity strengthening. Second is doing the research, which is the implementation research. Third is how we can transfer this knowledge to other part of the world. And fourth is how we can engage the community and involve them in their own care as the stakeholders. So with this, the research was mainly concentrated on assessing the burden of the diabetes, endocrine, cancer, and other disorders, which causes a lot of burden, identify the case mix in the form of implementation research, co-design the intervention, and then pilot the intervention, evaluate the impact of the cluster randomized control trial. This is a very important for the postgraduate student, that is the research capacity strengthening. And they found that the AIMS Jodhpur is already conducting so many workshops on research methodology, and they are involving the young generation for the research methods. And that also required, that is, what is the extra need of the AIMS Jodhpur, which can be satisfied by doing a research capacity building in this area. And they gave us 3 PhD candidates. So this 3 PhD is a split side PhD, which will work mainly in AIMS Jodhpur and partly at University of Leicester. There are 3 postdoctoral fellow and 4 master's degree. So master's degree of 1 year full time, they have to devote the time there, and there are 5-6 areas in which they can take the masters. So this is open for anybody in our institute, and their regular advertisements are being conducted for these. Now for the PhD, what they do is they identify the needs of the AIMS, and they also identify the needs of the candidate. So they develop the research facilitation workshop. These research facilitation workshop are focused on the precision medicine idea, which has been acquired by the different clinics and the hospital data. And this develop the capacity of the people to conduct a research which is of implementation nature, and also from the individual to the institute, to the community, to the country. That is their area, how we can develop the capacity of our country for the research, which is, and we have much more better research capability than UK. We are much more advanced than the UK in many of the aspects. And we presented these programs, they were very much surprised to know that these are there, because they are facing the problems and challenges now. And we are the people who can suggest the solutions. So India is going to become the much larger in this area. And community engagement is one part where I say that the tribal people can be involved, the community people can be involved. Although this topic, the title appears to be very simple, community engagement and involvement, but this is the very, very difficult part. When you try to engage the community, you need some stakeholders, some Gram Panchayat members, leaders, some of the people who have cured from the cancer, diabetes, or they are well controlled on the disease. So they becomes the advocator, and they also develop the network with the other people. Also, this is very important that they share their lived experience with all the other people and involve the centers in overall activities. So AIMS Jodhpur has this Global Health Research Center, multiple long-term condition team in which there are different departments and different areas are there. First is the community engagement and involvement. The second is the training and capacity building. Third is the knowledge exchange committee, which can summarize the information which can be disseminated in form of infographics, and monitoring and evaluation learning committee. This monitoring, evaluation, learning is also very important because it enhance our working. It also increase the efficiency, and it also improve our health of the society. So all these things, starting from the Morbidity Clinic, which is a simple presentation, lead to many of the ideas. And what we say that when we start thinking, your neurons start working and the dendrites start working, and they are connecting with each other. And that is what is the mind space. And that is what we launch on the World Mental Health Day on 10th. That is a dendrite club in which it is being organized by the students for the students. And it leads to networking among the postgraduates and the undergraduates. It increases your efficiency in the community participation, increase your capability to present an idea, get a feedback also, and also make you more resilient to work under the stressful conditions. When you are under stress, how to work, how to be very effective in a short time, how to present your work to the audience in a much more comfortable and confident manner. And that is what we are getting the feedback from the people, residents who are visiting the community. They are now feeling more confident because here they are working under the supervisors. and they don't take their individual decisions. They are taking their own decision. Compared to the MBBS, the postgraduates are much well informed, so they take a better decision. When the MBS students are also posted, they will definitely get much more better knowledge. And I think this family medicine, which is based on the precision medicine and the long-term conditions, is not only going to enhance the post-graduation training, but also enhance the learning of the MBS students and the BSc nursing student. So with this is a short presentation. I had presented my idea how we can improve our morbidity and mortality clinics for a better outcome. Thank you. So this is our team, but this is not the list. It is still growing. So at a time, the whole of the institute will be in this team. So this is a AIMS collaborative project. Thank you. Any questions, any comment, suggestions are welcome. So right now we also have the students from the tribal area. They are also connected. Let us see if they are. So they are sitting there.
Only aspect which preventive aspect have to be stressed more, I think.
Yes, sir.
The preventive we are all the programs appear like it is we are more towards treatment of conditions in the society. We will have to develop something, I don't know how. So, and we have to go towards prevention of diseases in the society. So these are very attractive. I have seen these myself, and these are going a long way. They are going to a long way, and I think it will be appreciated and accepted by in the country and around the world. But preventive aspect, we have to stress a bit more.
So you are very right. Actually, AIMS Jodhpur is also center of excellence for rare disease. And rare disease is those which are not seen commonly. And what is not seen commonly is that either they don't manifest early, or they have a very rare manifestations. So rare disease not only include the genetic disorder, but other disorder also. And sometimes there are some problems in the society which we don't see. And also, again, it depends on our understanding of the disease process, our interaction with the society. So rare disease also, one of the screening program has been launched for newborn metabolic screening program. It has not been successful because it requires a lot of screening programs require a lot of logistics, and also the good epidemiological workup, because what area you are getting the cases, that needs to be strongly inbuilt into the true diagnosis of those patients. So again, a linkage with the diagnostic service is very important. And AIMS Jodhpur is a laboratory, a large laboratory, and the community is another laboratory, which is a extensive but a small laboratory. So if we do experimentation, some in the large area under supervision, under well-guided mentorship, and then we can extend to the smaller laboratory in the community, which is extensive but is smaller. They don't have the resource to do so many investigations or the surgery. But if we translate the tertiary care services into the community, I think that is the answer to your question about the prevention. Prevention is not only that is we do the screening, it is awareness also. And the government is trying now with the Ayushman Bharat. There are multiple components. One is the Ayushman Bharat PMJY scheme, in which there is insurance, and most of the people are aware of that only. But there is a very important component that is known as the health and wellness centers. The people have not understood in 2018, when September it was launched, what is the concept of the health and wellness centers. They are busy in building the equipments, they are building the infrastructure. That was not required. It is just take help of the nearby school, spread the information to the children. From the children you reach to the adults, to the family members. They will come for the preventive checkup and the promotive health care in the community health centers. So nothing is required in that area. But right now the concept has not been understood by many. We see that the healthcare at the doorstep. This is one of the word because of the community health center. But we tend to devote more time in the hospital because it provides safe learning things. And when you are in the community, you are exposed. Your knowledge is exposed. Your ignorance is exposed. You're not able to diagnose the conditions. So that's why the people don't prefer to go to the peripheral centers. If we can train like a umbilical cord model, that the tertiary care centers are linked to the peripheral centers and the people are updated regularly, I think this can markedly reduce increase the confidence of the people or the residents also.
Sir, basically preventive, we all talk more and do less. How many people at our AIMS campus go for the morning or evening walk? Simple. How many practice the diet? They don't require any cost.
Yes.
It is the basically habit building,
Yes, sir.
which should start from the campus, should go to the community, right? Simple thing to have the control weight, do the regular exercise, I think can prevent the many epidemics, right? So it's not only diabetes, hypertension, CAD, osteoporosis, falls, fracture, well-being, mental well-being, social well-being, everything can be simple, low cost, but it is to be spread. We all talk lifestyle in every disease, but how many practice that? That is the most important thing. We always talk of the investigation, screening, treatment. These are all the secondary things. First thing is the lifestyle. And probably we all in India is missing the part and missing the train which can prevent many diseases.
So you can see the lifestyle here. The CGR is meant for coming in the early morning, having our dendrite increase, but you can see the thin attendance. So again, you are very right. That is, this starts from the home, and we have to improve ourselves with the morning walk, lifestyle changes. Then only we can advocate about the community.
I think next director we must tell that morning 5:30 all students will be in the ground and walking.
Okay. So for the benefit of the students who are there in the tribal, Professor M.K. Garg is suggesting that we have to change our lifestyle. And when you are there in the community, you should also make an effort to have a walk around the campus, see the other people's, their life also. Okay, sir. Thank you, sir.